Hey guys, welcome back to the Junto with Scott Radigan. The whole point of this show is to bring in experts like the one we've got today. And I'm very excited to bring her in because at our Functional Lawyer Practice Protection Program, we talk about Medicare and opting out and all of the regulations around that pretty much every week at our office hours. So I'm happy to bring in Sonda Kunzi from Coding Advantage. We are going to talk about whether opting out is a good strategy, whether staying in is a good strategy, what that all looks like in a practice that's delivering functional integrative medicine. So we cover all of it. And there's actually a bonus recording at the end where we finished our recording and then we kind of came back afterwards to say there is a lot of news right now in March of 2025 where the Medicare telehealth coverage is about to fall off a cliff on April 1 unless Congress acts. So we talked about what that's going to be like and what we predict for the future of there. But hope you enjoyed the episode with Sonda Kunzi from Coding Advantage. Here we go. Sonda Kunzi is a healthcare consultant with over 35 years experience specializing in ICD-10, CPT, HCPCS coding, compliance, reimbursement, and documentation. Her background includes working in hospital-owned and private practices with a strong focus on behavioral health and functional medicine. Holding multiple national certifications, she's known for breaking down complex healthcare topics into practical, real-world insights. And her passion is to share her expertise with providers and discuss key strategies for navigating the ever-changing healthcare landscape. Welcome, Sonda.
Thank you so much. Good to be here.
I'm very excited to have you today because I know that at Functional Lawyer in our weekly office hours, we talk Medicare probably 3 out of the 4 weekly office hours we have every month. It's a topic. It's a hot topic because it is as you know, highly regulated topic. So I'm excited to get your take on all of this because frankly, after a long time researching it myself, it's not easy to understand. And I've tried to break it down as best I can for my clients, but there's always still questions. So I'm so excited to have you.
All right.
Before we get going, yeah. So before we get going, Sonda is the owner of Coding Advantage LLC, which can be found at codingadvantage.com. But how did you get into medical coding?
Yeah, that's a good question. And I did have a parent, my mother, who was a nurse, and I did study with her when she was going through nursing, which happened to be in my high school years. But I realized that I wasn't really a fan of blood. So there was no actually going into medicine or in that direction at all for me. And I think through experiences I worked for Blue Cross Blue Shield out of high school. And that was where it really became apparent to me that I loved the claims process and doing the work. And I was able to do that on the back end. And then I came out of that and started to do it for practices, which was really great. And it's a whole 30-year career of being with practices in a consulting agreements and in general doing a lot of compliance work. And in the last 10, I would say for sure, a lot of work in functional medicine and helping these practices understand it because it's super complex. And then with behavioral health, that definitely is a passion of mine and helping those organizations who are really helping the public deal with addiction and just holding them up and helping them understand what the rules are too, because they deal with Medicare as well.
Yeah. And so I know most people would be like, man, who would ever want to be a coder? But when you put it that way, where you are helping people indirectly or one layer removed to really change someone's life, that's a good reason to get up in the morning.
Yeah, it's exactly that. It's paving the way for them to get paid for what they do best and have them not have to be so concerned or all consumed with that reimbursement process and deal more with the patient.
Okay, perfect. So let's dig in because as I said, we get lots of questions. So if you could, one of the bigger things, because most of my audience is in functional and integrative medicine, and most of them are approaching it with the assumption that cash pay is really the only sustainable model. But I want your opinion on that. Do you see a lot of practices that have both insurance and cash pay working together?
Yeah. So this comes up quite a bit too with people that reach out to me from the functional medicine community. And I don't want to pretend that a hybrid model is easy or simple. It is not. It's complex. And you have to learn what can be done under insurance and what has to stay cash. And if you can do that and try to understand that the insurance piece tends to satisfy the patient in use of their particular thing that they're paying for, their plan, they're paying for it, they like to use it. So in that, you can figure out a way with the chronic conditions they may have or certain things that are going on in their lives that they can run through their insurance. And then also remember the reason you're in a practice and in functional medicine, or sometimes concierge, it depends, but specifically in functional medicine and getting to the root cause, some of the time they spend, some of the things they do, some of the way that they approach treatment may not be accepted by insurance. And it's about educating their patients. That education is really key in saying, I will bill to insurance. I do it for this, but please remember, this is my practice. This is what I'm doing. And this is why you want to come to me. I'm taking care of you in this manner. And if it means that we do outside the box of insurance, you're really going to benefit from it. And I think that's really key, education to the patients.
So let me ask you, what are some big no-nos when somebody is trying to fold functional, integrative, whatever, value-based care, personalized medicine, longer visits into an insurance billing code submission? So I get lots of people that come to me and they say, well, I tried to incorporate functional integrative medicine into my current, traditional conventional practice, but I just found I couldn't make it work. So what I'm trying to get at is, what are the big no-nos when it comes to using insurance, like balance billing or sticking codes in there that probably shouldn't be in there? What do you see most commonly?
Yeah, I think both of those things are very common in terms of stacking. We call them stacking codes. I can get paid for this, 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 and that, but they don't necessarily know the administrative piece that goes with it in order to qualify for those codes. So that happens a lot. They hear that, oh, you can do behavioral health obesity training and intervention in this code, and you can do this on this code. And they can all be done on the same day, and that would take up the hour that you normally do. But people forget it has to be documented like this, and I have to have these 3 pieces in front of it, and I can only use this kind of provider. And I think that's a big deal too. I don't want to get too far off what your question was, but using the wrong provider and then billing it with a code that's for like a licensed provider. As we know, that health coaches are a big part of functional medicine, but they just don't have any direct reimbursement, and they can work in general supervision for a lot of codes that are out there. But we get in trouble when I've heard things like, well, the health coach saw them and they billed an office visit, which is really way out of scope. But if somebody doesn't know the rules or doesn't, you can't do the ignorance thing because there's too much out there about them. You have to learn what you can and can't do with scope of practice. And that's a big no-no. And I think that gets a lot of people in trouble.
Okay. That was my next question. What kind of trouble are we talking about?
Yeah. And trouble means this. I mean, a lot of times what will happen is a provider gets the wrong information from a consultant, or hears they can bill a code from an association. That thing seems to be like, it comes down from an association. You can bill this new G code, and they do a ton of them, right? They're told they can do it at every visit, and they do it, and they maybe had kicked that to their health coach. And now a patient sees the bill and says, well, I didn't see that provider on that day, and asks the question. That's what opens it up, right? If a patient has a question of, well, I didn't see Dr. Jones that day, I only saw the health coach. That like opens the lid of Medicare wanting to look in, or even a commercial carrier. And then when they do look at the records and it doesn't show what it should, that's where they start getting in trouble. And I think that not understanding all the regulations from insurance carriers and from Medicare and what they expect to be behind the scenes in the documentation is really a disservice. You have to understand those in order to bill. And again, it sounds like a huge lift. It's not. If this is what I like about my job. If we take it, what are you doing when you see your patients? That's how I start. Tell me about your model. Okay, you can use this code in your model. You can use this code, not this one, because you're not doing that. So we need to take that out. Even though the association said that pays you a lot of money and it's an easy, don't do it. Because you can go years thinking you're doing it right, and then they're going to go back years. And that's where people get in trouble.
Okay, what kind of trouble are we talking about? Are we talking about going to jail, getting our license suspended, or really big fines? All three? Some of the above?
It doesn't escalate that quickly.
Yeah.
So the first thing it happens is if they look at your records and they're going to ask for an overpayment back, right? They're going to tell you were overpaid, and sometimes it reaches a whole nother level. And when it reaches the high numbers, you get an attorney involved because you want to make sure that you are covered in terms of what their interpretation of what you're doing and things like that. So there's a lot of that piece in it, but that happens first, the overpayment. And if they see your pattern continue when they've asked for that money back before, then they're going to do it again. Then it starts to get up to the investigative level. If it's really a ton of work for them, they may kick it to what we call UPIC, which is basically another level of investigations. One of the things I need to tell everybody is on the commercial end of it, we're seeing more special investigations unit involved in the first level. And that scares people. And really, that happening doesn't mean you're wrong. It means we've got to make sure that everybody's interpreting things right. So in trouble, yes. You're probably going to have a ton of overpayments at first. Then you're going to start getting a little the next level as it continues. So I don't believe anyone gets into really bad trouble, jail or otherwise, until they've continued the same behavior after being told not to.
Okay. So jail's off the table, at least for now.
At least for now.
If you shape up and the quote unquote cops tell you to stop. Overpayment, are there any interest or fees that go along with that? Or is it really strictly just someone paid you 100 instead of 80 and you got to give either, we're talking about commercial payers here, or are we talking about Medicare?
Yeah, we can do Medicare or commercial. Medicare is the first one is going to come back with a full payment amount that you owe them. And it'll be something like, there was even a mistake. I can give you just one example, a provider who did not get his reattestation in, or something had happened, or Medicare, if I remember correctly, Medicare made the mistake on their end, but every time we tried to call and mitigate it, they didn't want to hear it. They wanted their $100,000 immediately. And so he ended up paying for it. And then it took 2 years for us to get it back. And it was a Medicare error. So I think we have to think about two things here is we have a ton of AI and data analytics. So if you're going to be audited or get an overpayment letter, you just don't take it for this is what it is. You have to investigate it. And that's part of it. And when we say kind of jail's off the table, it's one of those things is the intent. When you have bad intentions, it's really actually kind of evident when we start looking at your billing patterns. But if you're just making a mistake and now you're told, don't do this, and you say, okay, I've made the error, I'm paying back the money that I owe, then I'm fine. In terms of whether or not interest in that would be, if you totally ignore it, don't pay the bill, most of the time, if you continue to submit claims, they're going to take it out of the claim. So you're not going to have the opportunity of not paying it and getting an interest. It does happen, but it's a rare occasion.
Okay. When you toss out numbers like 100,000, I think most people don't have that in their bank account. So I would call that big trouble if I had to come up with 100,000 pretty quickly.
Me too. Right.
Yeah.
Right. Me too. That 1,000 really quickly. And many times when you actually investigate what happened and you give them like, well, I did it this way. And then I made a correction about 2 years in, even though you're looking at those claims too. And if you have a good healthcare attorney, they can mitigate that down. Or if it's just, it happened and I owe the money, you can work out payments with them as well. People say, no, they'll never negotiate. But if you're actually talking to the right people at your local Medicare carrier, right? Because remember, we have CMS, which is the big overarching federal government, but each one of those has max and a jurisdiction. And usually you're speaking to somebody directly there and you say, this happened and I don't have the money. And of course, they're going to say, but you have to pay it. And you can figure that out. Again, I think a good lawyer is a really big trick. Kudos.
I'm not paying Sonda to say any of this. But
no,
yeah.
I've been in enough situations to understand when there is a good one, what the difference is in the result.
Yeah. And at that point, you would want somebody in your state who does this quite frequently. I wouldn't be a good candidate anyways.
Yeah. We hope it doesn't get to that.
Right. And that's why hopefully people are paying attention and sharing this episode with all their colleagues. And so, for those that aren't aware, a MAC is
Medicare Administrative Contractors. So really quickly, what this does is Medicare themselves, right, does not have the resources to pay millions of claims per day. So what they do is they have insurance carriers bid for those positions, and they're in a jurisdiction. So like Kentucky and Ohio are together, and Pennsylvania might be one, and perhaps Maine and Vermont, and I can't think of all the jurisdictions, but then they are the administrator over the claims that go through. So your claims go there. They don't go to the CMS as a whole.
Yeah, I think there are 6 companies in, I think maybe like 11 jurisdictions that cover all of that.
Yeah, it's something I should know statistically, but do not.
I'm pretty sure it's 6.
Wherever my client is, I've got to know who the MAC is and what their rules are because they can vary.
Yeah, so let's go into that really fast.
Mm-hmm.
Because when I say to people, they have options. So I'll go 2 layers in first, and then we'll back it back up.
Sure.
When we talk about trying to bill Medicare for services and knowing what is a covered service and a non-covered service, what a lot of people maybe don't realize is that what's covered in jurisdiction A may not be covered in jurisdiction B. Because I know I am, asking you this question. I'm not telling you, but I know that there are different national coverage determinations, or NCDs, and there are local coverage determinations. Can you talk about that? Like, are they different across different regions?
Yeah, I think where you'll find the differences are this. So there'll be a national coverage determination, which is usually saying Medicare will cover this service if these few things are met. If they have this type of diagnosis, if you've done these few things. And there are a ton of those types of national coverage determinations. At the local level, they also can create these. Generally speaking, they can't not cover something that Medicare covers, but they can make the criteria a little tighter and say, well, you're going to have treated this patient with this option, this one, and this one. I need to see that documentation in order for you to get paid for this. I think that the local ones tend to be more restrictive because their medical director feels like maybe they know about the situation and they don't want people overutilizing the code or not. Or they have the most nuanced information to it. Like, for instance, they'll pay for a certain diagnosis that another carrier would not. So it sometimes is the medical director that's on staff there in that jurisdiction who may have a special knowledge about a particular specialty.
So is there a particular place where one would go to look in their jurisdiction for what is covered and what's not covered? Or is it less of a black A, and then B, is it clear cut like that? Or is it more of a depends on the circumstances situation?
I think it depends on the circumstances. So when I'm working with functional providers, I'm usually asking them, what's your model? What do you like to do? Are you a preventive person? If you like prevention, like running tests or doing this particular thing or screening for that, Medicare really allows for a ton of this where they didn't in the past, right? So in the past, these functional medicine providers were able to say, this is preventive and preventive's not covered. We can't say the word preventive anymore. Preventive is usually covered benefit. Wellness is still not. So they would say to me, well, I'm going to run this. I look at depression. I also screen for diabetes. I do this. And then I'm going to go to their MAC and say, out of all the things you told me, here's all the codes we can use. And here's your instructions on how that has to be documented. Now let's build that out so you can bill for these codes and know when you can and when you can't. We're going to base it on how they approach their patients. And sometimes it's not all there and they don't know exactly why. I see them. They come in the office. I get to the root, some of them can't get there. And then I'll say, well, do you do this? Do you do that? And based on their jurisdiction, I can offer services. Some of them say, nope, not going to do that, not going to do that, not going to do that, which is fine. It's about working with them and understanding what they want to measure with their patients and what we can do with the MAC and the requirements. Where, like you said, I might have somebody in, Ohio who can approach that particular preventive service one way, but in Pennsylvania, they have to have a special diagnosis they have to use, like an ICD-10.
So for somebody trying to wrap their head around this, one, they would go to somebody like you, like a third-party billing company, right, to kind of help educate themselves on this, right?
Yeah.
Otherwise, is it possible for somebody to kind of figure this out on their own if they don't have 35 years of experience with it?
Well, I think that if they are really great in looking up things like, I love to Google this or I'll get in that. But I can honestly tell you too, here's just a kind of a sidebar to explain how weird this is. So when telehealth came around, when we had the whole COVID thing, everyone thought they could look up the rules and use the search word telehealth, like a United Healthcare payer portal or this payer. And interestingly enough, it was all under COVID-19. So if you didn't know to look under COVID-19, you weren't getting the latest telehealth rules and you were following an old way of doing things. And we found that a lot. So I think utilizing or leveraging consultants where they know best are knowing what you want to do and them knowing how to get to that information properly.
So I wanted to come back because it struck me. Thank you for that. I think consulting an expert is probably always the best. It saves you time, definitely time, and probably money in the long run too. But I wanted to touch on I've heard from people, and I don't know where they get it, maybe a well-intentioned comment, an association or something in the past, that just a blanket statement, which as an attorney, I know to be wary of all blanket statements,
Okay.
but the fact that Medicare doesn't cover functional medicine. Is that true? I know we've kind of touched on it, but can you just disprove that one for me?
Yeah, Medicare and the carriers really do not say we do not cover functional medicine. I think that where that, I think myth maybe or old wise tale is that the way that functional medicine does business is they don't, the average office visit is only 7 minutes. It's like 7 minutes, 46 seconds or something like that. There's somebody did a survey once and I was not shocked to see that. Certainly never would a functional medicine fall into that. But generally speaking, if you're going to your primary care and you're not dealing with functional medicine, you can see how that works. They're in, they're out, you're fine, you're done, you've got a medication to use, where functional medicine spends a lot of time. And if we were to make a blanket statement that that's all payable, we would be incorrect as well. There are codes that can be used, but then we have to be able to accept when that, spot of reimbursement stops for an insurance carrier and that it's just part of your mission to take care of your patient. And then we get back to is that enough revenue to sustain you? What can we do on the cash model side to foundation that insurance side up and we understand what we're going to get?
Okay, yeah, let's talk about that. How does one run an insurance practice? Some, not a lot, but some people come to me and they're like, well, I like what I do. I like the insurance. I want to just add functional medicine to my practice. I imagine that's a tricky or careful line to tread. How does one kind of do that? I know you probably have to go real detailed, but just in general, how does one kind of navigate that? Are they creating a separate entity, or are they just bifurcating their practice into different service options? Are they seeing conventional Monday, Wednesday, Friday, functional Tuesday, Thursday? What are some of the more common ways or safe ways to do that?
Yeah, so interesting. I'm sure you're in the space a lot. So all of the above, you have to figure out what works for you. I think that it's very hard to segregate only functional medicine patients on certain days, although that can be done. And that just, again, is about patient education on how you approach your practice and being really open with them on that. I think that I have seen some do another entity or another LLC that is the wellness piece, and that's fine as well. I think that hybrid wise is that we kind of have to look at it like, okay, are we going to charge a membership? And that's over here because that's never going to be paid by insurance. And then what does that membership cover? And we do have to put that to the test of none of those are insurance. And then we come over to the insurance model, and they have to have that mentality that insurance does pay for a lot, and we have to know what you're delivering as far as your services on whether or not we can build these codes. I think that where I don't see it working is when they're saying, okay, I'm going to spend an hour. I need a reimbursement for an hour. I need every insurer to pay for an hour. I can't do this. Well, guess what? This is going to be a problem because we may not be able to do it. And there are things right now in the description of CPT that lets us bill per, I should say by time spent. And then there's prolonged service. But then we get caught with not every carrier likes prolonged services. And, that's a really big thing too, is they see a CPT code for it. They're like, there's a CPT code for this. And yep, there is. But guess what? This insurer doesn't pay for that. This one likes it. This one doesn't. And then they get frustrated. And that's when, it doesn't work in the insurance model. I think that they have to have the mentality of what is their core value, their core mission, and can I extract that from them on the cash side and then teach them the insurance side? So, and some of them, well, I'm never going to do acute care. Okay. That, that means that there's going to be another provider involved. So for us to do chronic care management, we're going to have to hope that primary care physician that you're letting them see for they're seeing for their acute might want to bill that. There's so many things to think about. I think that taking the time with someone and really understanding how they want to deliver care and then giving them what insurance model is going to look like in a pro forma. You would have to see this many patients to make this kind of money that you are thinking through. Or
Right.
we have that in the membership fee and you increase your membership fee and do this all on the cash side and leave that over there. But that patient has to sign the agreement going, I fully understand this. And you know what? That works in some areas and it just doesn't work in other geographic areas. Sometimes that's the clincher. geographically, it just doesn't work.
And that's because private pay is different by state or MAC for Medicare or both.
Or even the patient base, right?
Mm.
So you could get to the point where if you're in LA or New York, you are definitely going to be able to run a functional medicine practice, right? If you're in Iowa, where you're in with a bunch of farmers, you may or may not be able to. Maybe they all like that and they all want that and they like house calls and telephone and the old way of doing medicine, and that might work. Or you might just be in an area where people are like, I can't pay a membership fee. I already pay for my health insurance. I pay $2,000 a month. I have a $10,000 deductible. I can't pay you. So in that kind of looking at the patient base.
Yeah, I will say don't discount farmers because we in Sarasota,
Yeah, I know. I was just thinking about that as I said it.
No, because I mean, sometimes
Actually,
they're the best. They're the best functional medicine clients because
yeah,
we have
they get
we have
it,
a
actually.
big Mennonite Amish community that comes down to Sarasota, Florida, where I'm from. They're the best. They pay cash. They want the natural remedies, and
Yes, I do have a
they're happy
lot
to
of
do it.
providers with the Amish community. And yes, they pay cash and they're very good payers.
Yeah, no, I did. I knew you weren't trying to disparage farmers, but we
Yeah, I was
understand
just
the
trying to
point
think
there.
of that. But
Yeah.
honestly, you do have to think about where you're living and the type of people and if they're not, if you allow, well, how do I know that? Well, go to the library and have a night of functional medicine, introduction to functional medicine, come see us. And if you don't get, a big crowd doesn't mean it's not there, but there's a ways of trying to test the waters where you live. Some of them have lived in a particularly small town for a long time, and then people know them and they can get the patients that way too. I don't want to project that not everybody likes functional medicine. We all do. It's whether or not we have to have a commitment to ourselves. It's just like paying for the gym. People are like,
Right.
I want to go to Plant Fitness because it's $10 a month. Well, you're not going to find a personal trainer there. Maybe not. It's the person's commitment to wanting functional medicine that really helps the functional medicine provider survive.
I'll add that if you just try one night at a library and it doesn't go well, that doesn't mean that's not a good
Doesn't mean it's not.
strategy. You should probably try it a different way or a different time, or just try
There's
it
lots
different
of
ways.
marketing techniques out
Give
there,
it
and
give it a statistically significant amount of effort and volume before you say this doesn't work. Paid ads don't work. Well, they clearly work because we have Super Bowls and everything else the rest of the year. Okay, so somebody is trying to make this work. What is like a person that is coming to you for your services? What are they typically? What's their typical pain point, if there is a typical pain point, or what would be your favorite client to see?
I think my favorite client to see is the person who has the incredible passion to take care of people, but also is open enough to not just want to throw the towel in when I tell them what insurance is like.
Yeah.
That they have to think that through, but they ask me, okay, does this mean I can't do this or can't do that, or that I wouldn't be paid for this? And when you say, that's correct, you're not going to be paid for that. Can we move on then to the next thing that you're thinking about? And they're like, yeah, I don't really like that, but I hear you. It's some of the ones that scare me that may have come to me that are already doing something that makes me nervous. And I deliver that message and say, you can't do that. That's not right. And they're like, it doesn't matter what you say. I've never been audited and I'm not going to get audited.
Mm-hmm.
And then I get scared. And then I say, I'm probably not the gal for you.
For sure. People want to hear what they want to hear, right?
Yeah.
Let me ask you this. Go ahead.
I was going to say it's a very small percentage of those who don't want to listen. It's very small, but you do come across those folks.
I mean, I'm sure that the people listening here have patients that are like, they only want to hear what they want to hear too. So
correct.
I want to get into opting out and all of the rigmarole that goes there, because that's the basis of a lot of frustration for many providers. But before I do that, what I want to ask you, because this is something, especially when it comes to hearing what you want to hear or only looking for advice that confirms what you would like to be true, is what is the insurance take on practices seeing patients across the country? So let's say you've got your doctor in Ohio and they're seeing somebody from Idaho, or maybe let's not make them rhyme, somebody from Arizona. What's going on there? Is insurance aware of this, or are there documentation guidelines that would help with this? Or is it just, is there coverage? Is there not coverage? And then without getting into malpractice coverage either.
Sure. So a person, let's just say the physician or the whatever provider is in Ohio and wants to treat somebody in Arizona, they must hold a license in Arizona. So you must hold a license in the state in which your patient resides. That's a big deal. And yes, I understand we have compacts between states, but it's very, very minimal where that applies.
And you said reside. I would maybe correct you to say located at the time of the visit. Is that accurate? Okay.
So yeah, I mean, let's say you're in Ohio and you're a provider and your patient is on vacation. That's a lot different. Chances are you're just kind of making sure everything's okay. They're going to call you. It basically means where they're located at. You do have to have a license. And I think that you're not going to see a lot of specific regulation when someone's on vacation. But honestly, let's not take this so literally that we skew what the actual regulation is, and it's where the patient lives. That's important. So if the patient is in Arizona and living in Arizona and resides, is what as
Right.
a person in that state, you do have to have a license in order to take care of them. Although, if you're going to ask me my personal opinion, this is ridiculous. If you hold an MD license, you would think that that would hold water in every state. That is not my cross to bear. I'm hoping at some point in our lifetime, we see that if you hold a license, you hold a license. I don't know the nuances of capability or scope from state to state.
I do. That's what I do every day.
There
So
you
if you're
go.
interested, here's my book, The
I
Practice of
am.
Telemedicine on Amazon.
There you go.
There just briefly as an aside, I don't believe there will ever be a national license, but I think at least for MDs and DOs whose scope is very similar across every state, there is going to be an easier way to get each state license that doesn't cost you an arm and a leg and require CEs for every particular jurisdiction. Now, I know people that
Yeah,
have
there you go.
52 licenses and it costs, use a consulting firm, it costs over 30 grand to kind of get that going. Usually not necessary. And I think more of the future will be kind of like you register or you get your license in state A, and then you kind of wave into the other states for MDs and DOs, right?
Right.
But for most others, the scope of practice is very, very different in every state. So
and
I'm
definitely in the
hesitant.
behavioral health world, it's miles
Yeah,
apart.
yeah, exactly. So I don't see that coming anytime soon for anyone not MDDOs, but there are plenty of special purpose licenses or special purpose registrations. Many of them are free if you're licensed in another state. And they're open to not just MDs and DOs. It just depends on the state. There's 21 right now as of early 2025. 21 states have some program like that, and the rest are working on it. Well, we hope they're working on it. All right, okay.
We hope they're working on it. Yeah.
So sorry for that aside. What about the person who is like, I can't handle all this. Let me just opt out. I'll be all cash, which frankly is mostly 98% of the people I see. Let's talk about opting out, because a lot of people come to me. So they come to me and they say, all right, I want to charge cash in my practice, but I'm working at the hospital still. What can I do? So what would you say to that? I have my answer that I talk about every week, but you tell me.
Yeah. And my answer is you can't do that. You're a one NPI, right? Your national provider number is you, and you're attached to it. So if you are working at a hospital and you are attached to that hospital as a participating provider in Medicare, you cannot go into a private practice and opt out. You just can't do it.
Right. And so I just say you're in everywhere or you're out everywhere. You can't be on both sides of that line. So then what are some options? Like you said, with the state licensing, it's maybe not ideal, but it is the rule and the law of the land. So what about somebody who is like, what's the big deal? They want to pay me cash. I'm a participating provider in Medicare. Is there any way for me to charge them cash at my private practice?
Yeah, I think, as we know, saying absolutely not, or never, never,
Right.
never, or saying always, always is wrong. So depends on what you're providing. I mean, the chances are the services you're providing would be uncovered. Again, like we said, most preventive are something that's covered under Medicare. So you're not going to be able to do that. But if you're doing something in the line of wellness, if you're, holding a yoga class, doing yoga with your patients, then fine, charge cash. So it's not an always or never situation, but my instinct is to say most often you may be providing benefits, covered benefits under Medicare, and then you cannot ask the patient for cash. That definitely can get yourself in a little hot water, that's for sure.
So this is the second time you've brought this up. For the uninitiated, including me, what is the difference between preventative and wellness?
Sure. So prevention, again, has a list of things that are covered. I'm sure some folks may be familiar with the United States Preventive Task Force. A government, right? Government has now created a list of things in Group A and Group B. And you can look these up. And there are certain things that an insurer must pay for. Now, again, you'll have exceptions like the grandfathered in policies and stuff like that. That would take so much time for us to figure out how many people you see with those. But in general, plans need to cover certain preventive services, such as screening for diabetes or obesity and colorectal cancer screenings and what have you. There's a list on Medicare that refer back to Group A and Group B, and the commercial carriers of, well, again, as long as they're not grandfathered in, we'll have to follow this. And so with those things, something that happens is they do it without a copay or deductible. They are agnostic to that patient share part because they're covered under these groups, which makes them a full covered benefit. So where 10 years ago, where our functional medicine were doing preventive, and this wasn't how the insurance industry felt. Prevention has just come around, I think, in the last 10 years. And I'm older than that, so I remember when it wasn't covered, where you would go get an annual and it wasn't covered. But in general, we're going to say that 80% of things that you do under a preventive reasoning, like to prevent further disease process, to prevent something from happening, either through a lab test or a screening of sorts, it's probably going to be a covered benefit. Wellness, on the other hand, for me, again, I did have my client who said he did meditation in his yurt on his property. And you would think, okay, that's what you like. But that he had an incredible following for that. When I actually got involved in it, I was like, wow, I didn't know. Just because I don't meditate, I didn't see how big that was for him. I had another one in Columbus who, like I said, did yoga with his clients. And you would think some people don't want to do this. This is not where they're at, but that was his passion. And his classes were waitlisted, right? But those are his patients, and he showed the benefit of doing that. So the way that functional medicine approaches treatment options is not our normal, but the measurement of certain preventive for disease process is usually covered. So that's how I look at it.
All right, so the typical thought process is somebody comes in, they get a blood panel, and even though we are not doing, or usually we're trying to shy away from prescription medicine, and we're trying to shy away from insurance coverage, a lot of people mistakenly believe that that's not really medicine. But you're saying like the blood panel, or later on a Dutch test, GI map, whatever it ends up being, plus customized protocols, whether that's lifestyle interventions and supplements only, is potentially covered under private pay and or Medicare, or both.
Yeah, I don't know that I'd go to the extent of all of the functional medicine lab panels that are run. Some of those are covered for certain reasons. If people
Sure, excluding the labs, just the doctors,
yeah.
just the actions. So let's take the labs aside for a second. Like that is potentially a covered visit, is reviewing the labs, giving them a protocol. Yeah. Okay. Just want to make sure that's explicitly clear.
Sure.
Okay. So before, and I want to get into details of how to opt out, if that's for you, like what are the restrictions there too? And, I talk about this a lot on my own, so that's okay. But I want to kind of come back to, I know it's not really like set in stone. And I know we chatted before we started recording about this a couple weeks ago, which was there could be a way where somebody who is in Medicare as a fully participating provider does charge cash to patients for covered services. And my understanding, and please correct me if I'm wrong, because it's been nearly a decade and I still I'm trying to wrap my head around all of this, is that if, a lot of people will say, I just don't accept Medicare patients at my practice, and we can't accept Medicare. But if somebody is, wealthier, has some cash and says, that's okay, we don't need to run it through Medicare, I'll pay you cash, what is an appropriate response? Are they supposed to just keep saying no? Or is there a way forward after that?
So this may be, as the type of attorney that you are in the healthcare in this industry, something that you would answer more than I would. So this is the way I look at it. You can say exactly what you said. You can say, I'm not going to see Medicare patients. And then you're fine. You're out of it. You don't see them. You don't deal with that. Then if you say, well, I would like to see them because like you have the wealthier that might be on Medicare, then you're better off to be an opt-out provider and have the private contract so that the patient can pay you. And then the claim never goes to Medicare. And it's a contract from the patient that says, I realize we're never going to bill Medicare for these services and they may be covered, right? It's that I'm an opt-out provider. I don't have the right to bill Medicare, but you want to see me and I want to see you. And that's a private contract. And believe it or not, you can submit to secondary insurance when you're an opt-out, you can. So it's a little harder. Again, your billing group has to know what they're doing as far as sometimes they'll want to see a copy of the contract along with the claim, and you can do that. So that's really the only way that I see legally to do it. And again, I'm not an attorney, so I'm good for you to answer that, because if I'm par or even non-par and I try to get cash out of a patient that may be something it covers, I think that's just an area you don't want to be in.
Yeah.
Unless we're absolutely sure it's statutorily excluded.
Right. Yeah. So it's, I kind of walk through all these options with my clients, and it's still not fun. There is a way to go forward, but it is very fraught and risky. And so I kind of I lay it out, and it is difficult. You have to go through that and play the part and say, I'm not seeing Medicare patients. And then they have to, on their own volition, come up with the idea, well, what if I just paid you cash? And so I think the opportunity for that to go awry is pretty high.
It is pretty high. And I think what we'll see is that providers will say, I'm just not going to see any Medicare patients. And then there's somewhere where the patient says, oh my God, this guy's great. And they go, okay, my friend will come see you, but they have Medicare. And you either have to say no, because what we see is, well, can't we just see them and get cash? That, again, like you said, that can just turn all kinds of bad. And your risk tolerance would have to be extremely high, and you're going to have to walk a very thin tightrope that I wouldn't recommend.
And on top of all that, you can't just charge your regular rates. There is what's called a limiting charge with Medicare, which is getting real technical now, probably beyond the scope for this conversation, but it's really still whatever Medicare would pay plus a nominal bit above that. Even if you did all that stuff and did it all correctly every time, you're still limited to what you could charge. So I tend to not recommend it. So then, therefore, thank you. So people it's actually more complicated probably than just billing Medicare directly. So people that have their practice and they're like, I don't see Medicare patients, but I have a job at the hospital. Once they get to a point where they can feel comfortable taking the leap and going over to their practice full time, and then potentially opting out. Tell me more about opting out, how that works. What are the restrictions? It would remove billing out of the equation. So tell me your thoughts on that.
Yeah. So an opt out is a conscious decision for a provider to say, I am not going to be working at the hospital. I'm in my own practice and I choose not to bill Medicare, but I want to see Medicare patients. So it's basically an opt-out agreement with it's through the Medicare administrative contractor that has the paperwork, and you fill it out, and basically it's in place for 2 years. And then there's certain things you have to do as you get to the renewal period if you want to kind of change that status or anything like that. So you have to be very aware of the 90-day mark, the 30-day mark, and all those wonderful things. But opt-out technically is every 2 years. And that did kind of, again, here's where something goes wrong, is during COVID, that was like, you can opt out, opt in, opt out. There was a ton of things waived at that time. And hopefully no one got too used to that, because then, of course, once the public health emergency was over, they reinstated their 2 years.
Yeah. And so to be crystal clear here, if you opt out, that means at your other jobs or moonlighting or all of that, anybody that you see that has Medicare, your employer cannot bill for your services, right? So it is kind of a big decision. And as you touched on, it's a 2-year commitment. Although the first time you opt out, you have 90 days to change your mind.
In the first 90 days, right?
Right. Then, but generally what that does is give people the freedom to just enter into contracts with people as if they were a regular, I was going to say a regular human. Two consenting adults can enter into a contract and to, pay you your rates, your cash rates. Mm-hmm. And then you don't have to worry about billing Medicare or their assignment or non-assignment or partial assignment. And also, if you tick a box on the opt-out affidavit, you can get some of these labs covered if they're covered. And so your patients can still see that.
Yeah, to order and things like that. Yeah, exactly.
Yeah.
I do have an opt-out provider as a client. And so we do watch that quite carefully, and we help them with their renewals. So the patient contracts have to be renewed, and there's all kinds of things that occur. But he's done it for 20 years. He's doing a good job.
Yeah. And more, some people ask me like, well, if I opt out, then I can't get a job for 2 years. But more and more, there's so many more functional medicine and telemedicine companies that are really just cash pay anyways, that maybe there are not as many jobs available, but there's potentially jobs too.
Agreed.
Okay. So we've covered a lot of billing and wellness versus preventative, how to bill with insurance. And you touched on one thing that we didn't cover in a lot of detail, which is if somebody wanted to be in the insurance model, the private pay insurance,
Mhm.
and still get reimbursed for some of the extras that they give as a, whether it's time or whether it's some wellness or else. It's what I call concierge, but you might call membership plus insurance on the top of it. So it's a monthly fee plus basically a fee for service when they come in through insurance. Do you have a lot of people in that camp?
Yeah, they do this. I mean, again, if your patients don't understand, then there is quite a bit of questioning as far as why am I paying a monthly fee if you're actually billing insurance. So again, that education piece of letting them know, here's our contract and here's what's covered under that membership. These are things that aren't covered under your insurance, but I still want to give these to you, and getting them to understand that doesn't mean you're not going to have any questions, but generally speaking, that contract with the patient, with that membership fee and what you can and can't do under that. If they're a good educated patient, you shouldn't have any issues with that.
I think in my experience, people, as long as you explain why and that it actually benefits them, people are okay to be on board with it. Right. So
Yeah,
it's
and I
like,
think sometimes you have to be okay if you're going to lose like a long time patient. So I've seen it go both ways, right? So we have a traditional provider who is just sick of the grind, and he goes out to an IFM, a big webinar, is on a seminar or whatever, and then they get that feeling like, yeah, this fits for me. It's really hard to go back and fit that to your current practice. That is not an easy task. It doesn't mean it can't be done, because people have seen you for a long time and they get on your bandwagon or whatever we want to call it. But that's probably a harder lift than the functional medicine provider who has been kind of a cash pay, going, I'm going to venture out and step into the insurance world, one leg in, one leg out. And then his patients are like, this is awesome. So sometimes I would tell you it's harder for someone coming from the regular traditional mode into functional medicine. Can't say I don't want to say it's not doable. People will say, oh yeah, I did it. Great. And patients followed me. I had no problem. And that's just not the norm.
well, I might even say if you have a panel of 5,000, switching to a cash or cash plus model would mean you only need a panel of 500 or 200 potentially. And so, yeah, you're right. People don't like change. And so they're going to be asked to pay more. But maybe they're not the right people. And if this is right for you as a provider, you could still fill up, but you may not fill up with the exact same individuals as you currently have.
The old field of dreams, right? Build it and they will come. The people who do want that care.
Yeah, not good business advice, but good for building cornfield advice for
Very
sure.
good.
Yeah, you do marketing and sales is actually another piece. When you go cash, it's a whole different skill set that a lot of providers need to learn. And it's just a skill
just
set.
So you know, all this full disclosure is that a consultant who's going to tell you about what you can fill and what codes to use and how much to charge is not going to be able to help you with your marketing. That's a whole nother, somebody else has that specialty.
Yeah, for sure. Well, Sonda, I really appreciate your time. I know you're busy, so I want to let you get back to your day. Is there anything that maybe we didn't touch on yet that you were hoping we would touch on? Or in the absence of that, how would somebody who's interested in incorporating insurance pay into their practice get a hold of you, and what would the next steps be there?
Yeah, sure. So I do have a website, like you said, it's codingadvantage.com. And in that, you can read about exactly how I got into business and what we offer in terms of services. And you can click on the calendar to have a 15-minute free consultation and kind of tell me what you're looking at. And I can tell you whether or not I can help or give you some ideas, at least in that 15 minutes. You certainly can book a longer one, but there's a fee for that. But certainly 15 minutes does cover a lot when we just quickly talk about what you're looking for, whether you think you can do this or if you're kicking the idea around, we can talk.
Yeah, and you help people across the country. Is that right?
Yes, absolutely.
All right, so no limits. Sonda is the billing consultant that you never knew you needed, and we really appreciate her time today. Thank you, Sonda.
Thank you.
It's bonus time with Sonda Kunzi from codingadvantage.com. Sonda, thanks for coming back in. And as we hit stop on the recording, I realized that one of my clients asked me to ask you about Medicare and telehealth coverage, especially as we record this in March 2025. There is set to be an expiration of the telehealth coverage waivers that date back to COVID days on April 1st, 2025. What I'd like to do is ask you what needed to be in place for Medicare to cover telehealth way back in 2019. What has been the case for the last 5 years? And then what do we expect moving forward? So I'll start with the first one. So what was the original, like, what kind of telehealth would be covered by Medicare pre-COVID? And what were
Yeah.
the
So
requirements there?
yeah, and there are many.
Yeah.
I think prior to COVID, right, we had telehealth, but it was a service designated for those folks that had a hard time getting to a specialist or even lived out in an area where they couldn't get to their doctor's office. And that meant that there had to be a lot of requirements for that to happen. There's this whole originating site and site where the provider had to be, and it was a ton of regulations. So the patient basically had to be sitting in an approved facility where they could be contacting the provider who was at another facility. So this at-home thing wasn't part of that telehealth before the public health emergency. The public health emergency brought that on the home because we couldn't leave our homes, if you remember. And in fact, it was like March of 2020 where that happened, where we couldn't leave. And that opened the waiver to, well, telehealth needed to be wherever each person was. And during that public health emergency, all of those geographic and requirements, all those restrictions were waived. And so we had a very long time where telehealth was allowed to be a patient at a home, a provider at their home office or at their office or at the hospital, wherever they were, could make these telehealth encounters happen, and they were payable for sure. And then after the public health emergency, we had that moment where it said, oh, December 31st, 2024, this is going to end. And if I'm not mistaken, it might have been a week or two prior to that. I could be wrong, that got lifted. So with this March 3rd deadline, my expectation is, and this is just, again, my opinion, is that we probably will not hear the results of what's going to happen until closer to that date, and sometimes the day before. But here's a tip. A lot of times they like to send out these notifications on a Saturday. Don't know why, but if you look at some of the dates of these, the Saturday before something is going to happen, it gets pushed out when nobody's really, in their busy day looking for that guidance from Medicare. So if they don't extend it, we are going to go back to geographic restrictions and location restrictions that are really, you really need to be updated on and get yourself familiar with those, because chances are you're not going to qualify.
And to be clear, this is for Medicare covered services for providers who are enrolled in Medicare, either participating or non-participating. Okay, so what does that look like? You touched on originating site, distant site, and then you just talked about geographic restrictions.
Right.
Tell us, are we reverting back to those unless Congress acts?
Correct. We will be reverting. Yep. We will be reverting back to those if Congress doesn't act. I do expect them to act. I think that it would be very difficult for us to put the stop down. I think that with extending it, where their thought processes, and believe me when I tell you, this is just based on my experience and working in the business for 35 years, is they're trying to figure out the in-between. This is rarely restrictive, and we know that if we bring everybody back to this is going to make a big adjustment for our Medicare population, because some of them still aren't leaving. Some of them still have their feelings towards whether or not they want to be in public, especially during flu season. So that might be an indicator of what they're going to do. I expect them to push that out maybe 3 months if they haven't made the decisions on where in the middle are they going to meet. So if we can refer back to this later on, and that came somewhere in between the very restricted amount and what we had going on, I think that's where it's going to land. But if they're not ready to create those rules and put them in writing, then we're going to see it extended. But be prepared. If it's not, you cannot see a patient, or you cannot have a telehealth service with your patient being at home after the thirst for Medicare. And I think you and I both know that we tend to see that a lot of the commercial carriers will follow Medicare rules, which was evident when we saw CPT came out with those telehealth codes, and then they weren't adopted by everybody.
Okay, so we've seen this too with some of the telehealth waivers that are in place for DEA and prescribing controlled substances.
Mm-hmm.
DEA or Congress or both, I think DEA has pushed that deadline, that self-imposed deadline out, 18 months, 24 months at a time. So I imagine that if there's not a middle ground in place, they'll probably extend it. But assuming they don't, what are some kind of like high level requirements in order to get reimbursed for a Medicare visit, especially because some of these providers are only in business less than 5 years. So they may not have come under the former regime. So could you just give us that?
Yeah. And, for the life of me, I can't quote exactly what it is, but when we say geographic restrictions, we're talking about if you're in a location where there's a lot of providers available to patients in the area, there'll be no telehealth. If you're in rural or a shortage area, I think it's HS health something shortage. And there are some exceptions to that. You find it out, but you definitely want to, if you're in an area that doesn't have a ton of providers and you are either, servicing a client that's out in a rural area that can't get to you, those might be the exceptions, but there are specific geographic locations, and Medicare does list those in terms of what they call it in terms of a metropolitan area versus a rural area. And they'll list those and give you some zip codes and things like that, but it will be very specific to those who are allowed to have telehealth. And the patient, again, will not be able to remain in their home. They have to go to a site in order to do this. And just think about the administrative burden this is going to be. It just doesn't serve patients well. It just has to be done because that's the way it's been done. And for those of you who are newer in practice, you'll probably know geographically how you serve your clients and whether or not they're out in a rural area and whether that might apply. But I think getting close to March 31st and we're not hearing anything, make sure you educate yourself on what that impact will be if you're a big telehealth user and you have Medicare patients.
Yeah, and if you're doing this, like odds are you have an in-house or third-party biller, so have them monitor it closely. Or if you don't have that yet, talk to somebody like Sonda Kunzi here, and stay on top of it because it is changing, and that could mean a significant difference in your income.
Yeah, and the Center for Connected Health just came through on my email just as we're speaking.
Yeah, so I just told Sonda as I asked her to come right back after we finished recording the first time, and timely an email came out from a great policy organization, Center for Connected Health Policy, or cchcpa.org, I believe. And they put out lots of good content, and they just put out some good information on this. Again, it's a little bit of speculation because we don't know what's going to happen, but we're assuming the worst and hoping for the best and planning for the worst.
Yeah, planning for the worst and hoping for the best is the way to approach it. Try not to think that it won't happen. I mean, I'd like to leave you with that's my opinion, but you cannot plan your strategy based on that. You need to be, again, planning for what might happen and getting ready for that. And if it doesn't, then we'll all be happy.
Yeah. And so people aren't scared. Again, we're talking about people that accept Medicare, for providers that accept Medicare via telehealth. That small subset of people, this is who we're speaking to. But if that's you or you're considering doing it, this is something definitely to pay attention to.
Yeah. And as always, if you participate with payers, you're used to the fact that we always need to look at them to see what they're going to do and their response to that.
And private pay too. Yeah.
Yeah.
Exactly. Well, Sonda, thank you so much for all your time before and for agreeing to come right back in for this follow-up question.
It was an important one, right? We're in March.
Yeah, it's very timely. So again, appreciate your expertise. And you can find Sonda at codingadvantage.com, or her name is Sonda Kunzi, Kunzi. So thank you again, Sonda.
You're welcome.
Big thanks to Sonda Kunzi for not only recording almost an hour with me, but then coming right back on a few minutes later. Really appreciate her expertise at codingadvantage.com. If you guys like this, please subscribe and then let me know what you want to hear, who you want to hear from. But otherwise, hope you enjoyed it, and we'll see you guys in the next one.